Good evening. Welcome to tonight's Public Insights lecture. My name is Sally Shorthall. I co-chair the Public Lecture Committee and I'm a professor here in the university. Tonight's lecture is titled LongCovid, What Will Be the Legacy from the Pandemic? And it's given by Professor Chris Brightling. It's also the Jacobson Lecture. If you would like to ask a question, please do so in the chat function on YouTube. You can also ask us a question by tweeting us at InsightsNCL. We're always keen to get feedback, so you'll see a survey link below your screen. Please feel free to fill that out. I will be back after the lecture for a live Q&A with Chris. But here to give Chris a more fulsome introduction is Professor Andy Fisher, who is Dean of Clinical Medicine and Professor of Respiratory Transplant Medicine. So enjoy the lecture and I look forward to seeing you afterwards for the Q&A.
Good evening. My name's Professor Andrew Fisher. I'm Professor of Respiratory Transplant Medicine at Newcastle University, and it's my great pleasure to welcome you to the 2021 Jacobson Lecture. I'm delighted to welcome Professor Chris Brightling, who's Professor of Respiratory Medicine at the University of Leicester, to deliver this year's lecture. Chris is an international leader in lung diseases, particularly those affecting the airways, and he's an NIHR senior investigator. Chris has worked for many years in the fields of asthma, COPD, and other diseases affecting the lungs. He's also the chief investigator of a major study called COVID, which was awarded £8.5 million by NIHR to investigate the effects of COVID in the long term. Obviously, this is a very hot topic, and knowing what the legacy of the pandemic is going to be on the health of the nation is very important. Therefore, I'm delighted to welcome Chris to deliver his lecture, LongCovid, What Will Be the Legacy from the Pandemic? Over to you, Chris. And finally, I'd like to thank the Jacobson family for their ongoing support of our lecture program and the annual Jacobson Lecture each year, and Chris for dedicating the time from his busy schedule to deliver this year's lecture. Thank you.
Sally and Andy, many thanks for that kind introduction. I'm very honoured to give the Jacobson lecture this evening. And I'm going to be talking about the legacy that's now upon us from long COVID. And I'm a doctor who looks after people with airways disease. So I normally look after people with asthma and with chronic obstructive pulmonary disease. And I'm also a scientist looking into the causes and treatments for those conditions. And if we wind the clock back 18 months, we probably all can think of where we were and what we were doing in that sort of pre-COVID world, which almost seems a very, very long time ago now. And really, things have obviously dramatically changed, and COVID-19 has touched all of our lives. It's affected many of us personally. I'm sure many people watching now will sadly have lost loved ones to COVID-19. And people will have been affected in terms of their jobs, their careers, their education. And unfortunately, although we're lucky to have had great success with the vaccine rollout and the numbers of cases are going down, that many people who've had COVID are now still suffering with COVID-19 because of long COVID. So this is really the horror story that began to unfold at the end of 2019 and into the early parts of 2020, with pictures coming out from Wuhan in China, and then a little bit later in Italy. And really, when the pictures were coming out of Italy, it just suddenly felt very much that it was coming our way. Whereas these early pictures, it seemed horrific, but just seemed just a little bit far away to be thinking it was really going to impact in the UK and impact the whole world in the way that it has. And this figure really gives a map that isn't a map to be pleased about, but it's just simply showing the horror of the number of cases worldwide. So this is taken this week off the internet from the Johns Hopkins website, which then keep a record of all of the cases worldwide. So the more red the areas are, the more cases there are. So you can see in the boxes that I've put in here that worldwide, there's now been over 160 million cases reported, and I'm sure there are more that haven't been reported. And then from those, there's been over 3 million deaths worldwide. And in the UK, there's been approaching 4.5 million cases with 130,000 deaths. So really a terrible number there to be thinking about. We're also familiar with how in this country, obviously the lockdowns have very much mirrored what's been happening in terms of the discharges and the hospitalization. So what I'm showing you here is figures for the UK, and it's a timeline taking us from March last year through to May this year. And you can see the waves here with the first wave in the first quarter of last year, and then the second wave that really hit us, and you can see 2 bumps for the second wave in November through to December, and then in the early part of this year in January. And then we're very fortunate that the numbers really have started to drop off. And this is where that total of 460,000 of admissions into hospital for COVID-19 in the UK, and how it paralysed the UK during those times of its peak. Today, there's actually on the BBC News and BBC website, this title here, which is the NHS COVID Legacy, Long Waits and Lives at Risk. So this is not talking about the impact of COVID-19 directly, but the collateral damage that it then causes by the paralysis within the NHS, such that these two figures really tell a worrying story. You see on the left side, the number of people who are waiting for more than 52 weeks for routine treatments within the NHS, and this is data restricted to the people in England. And you can see here that it's a month-on-month increase such that it's now approaching 400,000 people. Then on the right, we can look at the same data, but this time thinking about it as the percentage of patients that are waiting more than 1 year for routine treatments. And you can see at the beginning of the pandemic, this was really quite an unusual event with fewer than 1% of trusts having issues at the start of the pandemic. But if you look across to the last few months, you can see that in February of this year, 35 trusts within the NHS had over 10% of their patients were waiting on lists for a year or more for routine management. So you can see that we recognize the direct impacts of the acute infection, we recognize the socio and economic impact, and then there's clearly a collateral impact on the NHS. So let's return a moment to the acute event. So what we know happens with COVID-19 is that you have associated inflammation. So you initially have the viral exposure, and then you have a viral response phase where there's an early infection. And in most people, this is short-lived. So in some people, it can actually be asymptomatic. In others, they may have relatively self-limiting symptoms. But in a small proportion, so in the minority, they go on to a pulmonary phase. So in this setting, they have a host inflammatory response, and this can then lead on to pneumonia. In some cases, that obviously leads into hospital admission. And you also have others which then have a hyperinflation phase. And this hyperinflammation phase is really where people then have a greater requirement for oxygen and end up on intensive care. And that's clearly exactly what we saw, especially in the 2 waves. So we had patients who then developed their viremia, then had changes developing pneumonia shown on this chest x-ray in the bottom left. and then ended up coming into hospital, and then many needing high flow oxygen or possibly going on to additional respiratory support, including techniques such as CPAP, and also ending up on intensive care for mechanical ventilation. We learned a lot from early studies such as the ISERIC study, but also from population data about what kinds of things actually were associated with severity of the acute illness. We know from this study that was published in Nature last year that there are a number of predictors for mortality. So to orientate you on the figure on the right, this is what we call a forest plot. So the red dotted line, the line of unity, means that if you look to the right of that line, there's increased risk. And then for each of the different parameters, we then have a comparator. So if you look first of all at the age group, you'll see that the bars that go to the right of that red line are with increasing age. You see then a risk with gender, with body mass index, with obesity, with ethnicity, deprivation, and also chronic disease. So in the middle, those bullets really highlight what those key factors are. So we know that predictors of mortality are older age, male gender, obesity, ethnic minority background, deprivation, and comorbidities. So what did we do? Well, we learned a lot in terms of about the management of the acute lung injury. There were changes in terms of the delivery of care. There were optimization of the respiratory support strategies. And those things really made a difference. What also was really important was early research. And the UK very much has led the way for platform trials during the acute phase. I'm showing you here one, the recovery study, and also the REMAP-CAP trial, which is also been a really important and insightful study. So in the recovery trial, centres across the UK, shown on the map, then contributed to the study where it was usual care against a series of different interventions. And the first output was for dexamethasone, this corticosteroid. And I'm sure you would be familiar with this study where it actually showed that there was a reduction in mortality and a reduction in going into intensive care and severity in those patients treated with dexamethasone versus usual care. And certainly in my centre, as was the case in Newcastle and across the country, there was really an enormous effort to recruit into this trial to really give us answers. And this was really our first breakthrough. And what we also found in this trial is that the benefit was greatest in those that had mechanical ventilation, shown here on the far right, label B, whereas the benefit was really very small in those that had oxygen only, and really no benefit seen at all in those that were on oxygen only. Unfortunately, there's now also been studies not only supporting this observation, such that this is really a very consistent observation, and dexamethasone and other corticosteroids are standard of care, but also there's been success with what we call biological or monoclonal antibody therapies, in particular tocilizumab. So there's really been some promising breakthroughs in terms of treatments. So that's really the early course of the intervention. So you have then detection, PCR positivity, and then the detection of the virus then drops off over the recovery period of those first few weeks. But you then have in the subsequent few weeks to months, persistence of really a whole cluster of different symptoms, which are then shown here, going from effects on fatigue, muscle weakness, through to anxiety, depression, problems with the heart and other organs, and persistent breathlessness and cough. And it's really this constellation of symptoms that have then really focused our attention and really made us think about what are the consequences of what's now called LongCovid. So NICE decided to, through its rapid guideline, first of all, define what we're actually talking about when we're talking about LongCovid. And importantly, LongCovid really is a term that was coined and developed by patients. And I think that's really important. And actually, I think in many ways, it's really the term that actually captures, I think, the essence of what we're talking about better than anything else. But to try and give it some kind of time course, NICE suggested that that you should call acute COVID up to 4 weeks, ongoing symptomatic COVID from that 4 to 12 week period, and post COVID-19 syndrome beyond the 12 weeks. And really then long COVID is then really used to describe those that have both ongoing symptomatic COVID-19 and then the post-COVID-19 syndrome, so really the last two on that figure. So very early on during the pandemic and sort of the end of February going into March, it was very clear to many of us that the real need was going to be trying to stop the infection, and that was through public health measures and through development of a vaccination. But there was a need to then be able to manage the acute episode better, and that really was the driver for those platform studies and other intervention trials as well. But because of our knowledge of what's happened with previous coronaviruses, post-flu and other conditions, that there is often a post-viral syndrome that really might be a feature of COVID-19. And because of that, we felt it was really important that we had a focus on patients who were suffering with COVID-19 infection and then what was happening in their recovery period. And we first of all focused on those people who'd been hospitalized for two reasons. Firstly, that we knew that they had COVID-19 because in the UK, to start with, as you will remember, we were only testing people who were in hospital. And the second reason is that we felt that it was likely that those people who were hospitalized might have more severe long-term consequences. So that was the rationale for starting the FOS-COVID study. And in this study, we have now set up a follow-up in over 50 sites across the UK, across all 4 nations. So the aims of FOS-COVID study are really very simple. We wanted to try and understand what are the causes, so the mechanisms driving the consequences of COVID-19 post-hospitalization. What's that impact? So can we then try and understand how that's affecting some people more than others? And what is it about the particular pattern of healthcare problems? What's the impact of intervention? So the interventions I've described, such as dexamethasone, tocilizumab, might they actually alter then your likelihood to get long COVID or the severity of long COVID? And thirdly, could we actually then develop platforms where we could then recruit people back for further in-depth studying, or importantly, then also have trial-ready cohorts that we can then start interventions? So how does the FOS-COVID study then actually fit into the wider context of COVID research within the UK? So I've put in the outer rectangle here population studies, and that includes the Office of National Statistics, Open Safely, so national, very large, big data studies. We then have for the patients who were hospitalized, the observational study, ISRIC, which also then has been following up patients. And FOS-COVID is very closely tied to ISRIC. And there are other initiatives focused on immunology, the genetics, the effect on the central nervous system, and the effects on specifically on pulmonary scarring, so pulmonary fibrosis. And all of these are very well connected with FOS-COVID. We then have intervention platforms, which I'll come back to at the very end. And we now have community studies, which are really starting up, which are then using and sharing data and data platforms with FOS-COVID and other studies. We also have set up a task force through the Department of Health, which is there really to try and drive policy guidelines, also to then help with specialist services set up, and this led to the network of clinics that have now been established across the UK for rehabilitation services, for research, and also to influence then the data going into and providing data to go into NICE. It's also important that we have healthcare research, which is embedded, also linkage where appropriate with industry. And also we're very mindful of actually that COVID is clearly not restricted to the UK and UK research, and working closely with other agencies, WHO, specialist bodies and research agencies across the world. With FOS-COVID, we recognize that the patients are likely and have had multiple problems. So really the patient is at the center of the study. And we very much focus on then collecting data on the symptoms, quality of life, and the clinics are run very much as a multidisciplinary team. And you can see all of these different elements from physical function, lifestyle, and all the different organ specialties that we focus on. We set up a working group structure that reflected this. So you can see the working groups described here. We have very close interactions with a number of charities who then also embedded with each of those different working groups. We have platforms for imaging, for looking at detailed scientific analysis with omics. We have bioresource, where we have collection of samples in a data hub, which is then matched to the data hub that's used for the ISERIC platform that I mentioned. And we're also particularly cognizant of the need to be thinking about PPI representation, which you can see here is strong with the charity groups, thinking about representation from ethnic minorities, social science and health economics. One of the early quick wins was actually looking at imaging. So the Seymour study, which is led from Oxford University, is now part of the FOSS-COVID study. And this is looking at multimodality magnetic resonance imaging. And this was looking at patients a few months after they were discharged with COVID-19 infection and looking at a control group versus those who'd suffered from COVID-19 infection and comparing changes in their MR imaging. And in so doing, we could identify that there were a number of patients where there were abnormalities, perhaps suggestive of organ damage in those patients. And to give that a quick summary, then we were seeing changes in the lungs in about 60% of patients, about a quarter in the heart, 10% in the liver, and approximately a third in the kidneys. We're not certain whether this is actual damage, but it's something that we're now following up in a much larger study of 300 plus individuals within FOSS-COVID. So the study itself is then looking at overall 10,000 individuals. 3,000 will be extensively assessed in clinic, 7,000 by routine clinical data. And then tier 3 then includes this recall that I've described and also the ability to bring patients back for additional studies. We're looking at patients in a relatively early phase at sort of 6 months, and we're now collecting data on patients that are being seen at 1 year. Our data collection includes some questions around recovery, very extensive survey on symptoms, and a whole series of validated questionnaires looking at breathlessness, fatigue, anxiety, depression, and PTSD. We also recognize that memory and brain fog can be an issue in COVID-19, and we're looking at that. We're undertaking physical performance tests and also looking at organ function. Our first 1,000 patient data has been reported in the national press and the national news. And just to give you some summaries of that, then we had just over 1,000 patients. They were predominantly male. They had a mean age of around about 58. You can see ethnicity was well represented with a wide predominance, but certainly had representation from other ethnic minorities. Most of the patients have been previously working. A number of them were categorized as obese at baseline, and a number of them had comorbidities. We included patients across the severities of the disease in the acute event whilst in hospital. So some required oxygen. You can see 17% had this non-invasive ventilation, such as CPAP that I showed you earlier. About a quarter were on intensive care. And a number of them had acute treatments, including the corticosteroids that I'd mentioned. Of those that we studied, 29% felt fully recovered. So that means that 70% didn't. And the mean number of symptoms overall was 9, and 18% were no longer working. And most of those, it was actually due to a change in occupation, and 20% actually had a new disability. I'm going to take you through some of the features that then actually were associated as factors of poor recovery or perceived poor recovery. And you can see here again a forest plot where less likely to recover is to the left, more likely to recover is to the right. And what we found is that the group of patients that were most likely to fail to recover, so the ones at most risk, were of middle age. They were more likely to be female and more likely to have comorbidities, and were also, interestingly, were not associated with the acute treatment. So the corticosteroids, which were very useful at reducing the acute event, did not have benefit in terms of then altering the perceived recovery. We also found that there was over 25% that had clinically significant symptoms. 12% had PTSD, and you can see this cognitive impairment here. There was organ dysfunction based on detailed testing, including imaging testing and also blood testing, and you can see that there was impairment in about a third, and there were abnormalities in terms of patients' ability to undergo walking tests. We wanted to really try and look at this in a little bit more detail, and what we did is we took the features of these questionnaires shown here, and we did a mathematical analysis where we did what's called a cluster analysis. When we do a cluster analysis, we can then group patients into those groups that are most like each other. And in so doing, we ended up with 4 clusters. And then we then do what we call Z-scoring, so that we're then looking at each of those different outputs by normalizing each of those. And in those 4 groups, we end up with one group that has very severe symptoms, one that's moderate to severe, one that's mild, and then one that's really less severe than the others. We also have one group that actually has quite a substantial impact on cognition, so this brain fogging. So I'm putting this into a map in a different way. So you have on one axis the breathlessness, fatigue, disability, depression, and anxiety, which largely tracked in those individuals against cognitive impairment. And you can see here the clusters as I've described them. And then when you look at each of those groups, then the first cluster was predominantly female and had a higher degree of obesity. They were the ones that were most impacted. The second group were the severe group. They felt recovered only in 9%. In the cluster 3, this was a group where there was an impairment in terms of their cognition. And in cluster 4, they still had ongoing symptoms, but they were much milder. This then gives us some clear differences then between what we're seeing acutely versus what we're then seeing in the recovery phase. So in the acute, remember, the predictors of poor outcome is older age, male, obesity, and comorbidities, whereas the recovery is then more associated, poor recovery is associated with being female, again, some association with obesity, but it's very much a U-shaped curve in terms of age, with the greater propensity to getting long COVID in middle age. And then when you then look at the severity, this is then fitting more, again, with female, gender, obesity, and comorbidities. So how does our data sort of fit in with what's been seen across the other centres around the world? So when we look over a time course, one of the earlier studies of long COVID was from Italy. And in this, they found 87% of the patients still had symptoms. Whereas in an early single centre study in Bristol, it was around 74%. And then looking at the 4 months time period in a single centre study in France, this dropped down to 51% in their study. We found around about 70% had still had ongoing symptoms. And then in the China Wuhan study, again, it was around about 76%. So clearly we don't know what the percentages are as we follow up towards a year, but you can see here that it's very common for those symptoms to persist post-hospitalization. We also know that there's impacts in terms of the overall healthcare. When we then look at healthcare records, we can see that a high proportion of people unfortunately actually die within those first few months after discharge. A number of them have ongoing respiratory events compared to a control group. And this is true whether you're looking at respiratory events, whether you're looking at diabetes, whether you're looking at major cardiovascular events, kidney disease, or chronic liver disease. What about looking at the community managed patients, and how's that then recorded through the ONS data? So the ONS data is then reported at the 3 months time point and suggested about 14 to 15% of patients have persistent symptoms consistent with long COVID. And then they've also now reported data from patients who kind of had follow-up for up to a year, but this was in a time frame in March and April. So many of those patients, it would have been a shorter time frame. But they then found and estimated that there would have been just over 1 million patients in the UK with long COVID. So this was in April. What they also found is that there were similarities in terms of the predominance in females versus men, and also this age around 35 to 70 as being really the time the ages where long COVID was most common. So let's just reflect momentarily on the type of symptoms as well, compared with those in the community versus those that have been discharged from hospital. And really there's a very large number of symptoms, and this is shown in order of the most commonest. And you can see very early on, breathlessness is a very common feature, whereas as you then move in towards 5-6 months, breathlessness starts to drop down, whereas fatigue, muscle pain, those kind of symptoms really stay very common as time goes on. And then from our data in FOS-COVID, as I said already, you can see that the median number of symptoms is 9 at that 5-month time point, so really very common indeed. So what is the legacy from the pandemic? Well, the majority of patients who've been hospitalized, and an important minority that have been managed in the community, they have persistent symptoms for 6 months after the acute illness. So there's clearly a need for a proactive approach to care. There's a very large, broad range of problems, suggesting that it needs multidisciplinary and interspeciality working. There's also a severity that we can then see, which seems to track both with mental and physical health impairment. And there's clearly, to answer these questions, an urgent need to try and understand the mechanisms behind this to direct personalized care. If we go back to the slide I showed earlier, and now put some estimates on to what the current numbers would be for long COVID, then worldwide, it would be in the order of 30 million plus, and that number will be increasing. In the UK, it's already over 1 million. And in those who are hospitalized, it will be approximately 300,000. So really very large numbers indeed. In terms of interventions, there's now a platform trial designed similar to recovery for patients who are being discharged from hospital with COVID-19, and this is called HIL-COVID. And there's also a recent call for research, which the deadline was this week, which then will lead on to studies which actually will be focused in the community. And there's also plans as well for other interventions for patients who have existing long COVID, who've been discharged from hospital. So a number of strategies which I'll be happy to talk about. And then on my last slide, I couldn't possibly give a picture of everybody who's been involved in the FOS-COVID study. I'm first of all just showing a picture of our own clinical team who are running our COVID clinic, and this would be representative of the over 50 sites that are contributing to FOS-COVID. I've also highlighted in picture Louise Wayne and Rachel Evans, who are my co-leads for FOS-COVID, and really been absolutely terrific with the wider FOS-COVID team to making this a success. And clearly there's been an enormous contribution from the patients, PPI team, charities, and then all of our governance structure and our funders, UKRI, Department of Health and NIHR. So many thanks for listening. I'm very happy to take any questions.
Chris, thank you for a super interesting lecture. I have many questions I could ask you myself, but I won't abuse my chair's privilege just yet. So the first question for you comes from James, and he would like to know, do any other respiratory illnesses or viruses display a similar range symptoms to long COVID?
So that's a really interesting question. And one of the things about COVID-19 is obviously the scale. So we're now able to learn an enormous amount what's happening after COVID-19, and that may actually in some ways flip the other way and help to inform what we then currently understand as other post-viral illnesses. We know also from pandemic flu that you can have some of the problems that I've described for long COVID, but it tends to be fewer, more self-limiting. Different risk groups as well in terms of those that develop the persistent symptoms. And there also seems to be differences in inflammatory profiles, which are now coming out in some of the early studies that have actually directly compared data from pandemic flu with COVID-19. So it seems that there are a number of similarities, but it does also seem to be revealing that there's also a number of things that are unique to COVID-19. And unfortunately, there are things that seem to be making it a larger problem.
Great, thank you. I apologize in advance if I completely mangled some of these medical terms because I'm not a medic. So Paul wants to know, do you anticipate an epidemic of pulmonary vascular disease as part of the long-term COVID spectrum, including both chronic thrombotic and pulmonary arterial hypertension?
I think you did a really good job there.
Thank you.
So we know that the blood gets sticky when you have an acute COVID-19 infection, which is the reason for Paul's question. And we know that there's an increased risk then of having clots in the lungs. There's also an increased risk during the acute episode, but also in that immediate recovery period for getting stroke and also for myocardial events. So this is a really important issue. And in fact, one of the first interventions that the Hill COVID platform is going to be looking at is actually continuing anticoagulation from the acute phase into that immediate post-COVID phase. So that will help to address how big a problem this is and also whether that intervention can stop it. Clearly, that's going to be too late for those people who are already coming out of hospital or those people in the community. What I'm pleased to say is one of those last slides I showed in terms of symptoms does suggest that breathlessness, although persists and still a common symptom, is less common as you then move on over that time scale. So that clearly doesn't exclude the possibility that there may be ongoing pulmonary vascular events, but it would seem to me more likely that those events have happened acutely or in that periacute phase. What I think is completely unknown, and that was part of the question, is the chronicity. So how many of these people have had events that have then happened with clots on the lungs or elsewhere that lead to organ damage that may not be that substantial now, but might then also impact on developing early chronic disease in many organs. And that definitely is a legacy that we need to be very, very mindful of. I think the MRI data will be really informative. So the MRI data was taken quite early, and some of the scans that we're going to be doing are at 1 year. And once we have those data, I think we can then more clearly either be reassuring and saying many of these things are actually now resolving, or it might be actually drawing even more light upon the problem and actually saying that there is ongoing organ damage and we really need to be very concerned.
Great, thank you. The next question is from Michael, and he asks, is there any research that indicates whether those who have long COVID have a greater chance of getting COVID again?
So the best data for this really is about how many people get COVID infection twice. So obviously once you've had COVID for the first time, then you develop an immune response, which makes you less likely to get COVID a second time. There are cases where there are exceptions, and there are cases where people have immune deficiencies where they've then had persistent viremia or developed COVID again. Fortunately, though, getting COVID for the second time is rare, and having vaccination programs also will make that, fortunately, to be continually rare. I think what is interesting as well, though, is that some people who have the vaccination can then develop some of the, some people have no symptoms, some have short-lived symptoms, and others actually can have a reactivation of some of their symptoms they get with long COVID. And at the moment, that's anecdotal, but that's actually part of what we'd also be collecting as part of FOS-COVID.
Mm-hmm. Lauren asks, How long do you expect it to take before we have more conclusive results on the effect of long COVID?
So I don't think we actually have that long to wait. So we're collecting data at 1 year now, as are many of those other studies that I described. And there's a tremendous effort around the sort of big data. So we can sort of think about the two types of studies as being collecting data largely from primary care, which are in very, very large numbers, but then don't have that ability to then do in-clinic assessments where they're doing additional biological measurements, imaging, and clinical tests. And then studies such as FOSCOVID, which are then doing in-clinic assessments where we're able to do those additional measures. So we will have the 1 year follow-up on the first 1,000 patients by the end of the summer going into the autumn. And then that will mean that we will have, from that data, we will have imaging, both CT imaging of the chest, some follow-up in terms of that multimodality MR that I've described, exercise testing, as well as all those questionnaires that I've described. And that will really give us quite a clear picture around trajectory. So if I can report back in six months or so that actually in the vast majority everything's resolving, then I will be absolutely delighted. It's one of those studies where I measure success as actually the whole study's stopping soon. Unfortunately, though, we've actually got ethical approval to follow people up for 25 years. And this is because I anticipate that there will be some, and I hope it's a minority, that might go on and actually have long-term problems. And it's going to be those especially where we need to try and get interventions early.
Is it possible that people who do not display symptoms of long COVID could also have symptoms longer term? So I guess I'm asking, can COVID cause damage that isn't visible through long COVID but might happen?
Yeah, absolutely. So if you extrapolate that small MRI study and sort of then imagine that people who were either asymptomatic or still definitely people who were in the community that were sick but didn't end up in hospital, because there were lots of people who were very, very sick because of the pressures on the NHS. People were staying at home at times when ordinarily they probably would have been in hospital. And I'm sure many of us can actually either name loved ones or people you know in that situation. Will some of those people potentially have had damage to some of their organs? Possibly, yes. And will some of that only really reveal itself later on in life? And I think that's likely. What I don't know is I don't know the magnitude of that, both in terms of the proportion nor the severity. So it may be something quite trivial, and certainly that's what I hope, or it may be something more significant. Interestingly, the community studies that I described, some of those actually include the same questionnaires, the same imaging approaches as we're doing in FOSCOVID. So we can then make direct comparisons across the severity of the acute COVID infection.
Great, thank you. So the next question is from Rachel. And in your opinion, could we have been better prepared for COVID-19?
So, I mean, in short, the answer is going to be yes. There was a few things that I think we did very well in the UK, although we could certainly have done better, is that we did have, it may not feel like it sometimes, we did have a pandemic preparedness for research. And certainly the ISARIC study, which it's largely led through the UK, although it's also a WHO initiative, had centres already to then go for an observational study for an acute pandemic. And that meant that we were able to get very early observational data. I think what we were not prepared or not well prepared for was really the scale and the severity of the pandemic, because it really just created such a paralysis across the country. But notwithstanding that, I think the UK actually has done, from a research perspective, has actually done very well in terms of really understanding the acute infection, understanding the mechanisms, developing interventions, and then also the vaccine story, and now LongCovid. So I think we have a lot that could have been done better, but also a lot that we should be proud of in the UK.
Great, thank you. And our last question comes from Emily. And she asks, are there more studies being done for people who have had long COVID for 12 plus months that were not hospitalized and therefore were not tested? And what help will be available to them?
So the simple answer is yes. So the community studies that I was describing will include people who had COVID-19 infection and did not go into hospital. So they will not include people who are hospitalized. The comparison there will be FOS-COVID. So those studies have now started. The call for those intervention studies was focused on people who had COVID-19 in the community. So there will be intervention studies that will then start later this year. And then there's also a network of LongCovid clinics, which are not restricted to people who are hospitalized, but can also be accessed by people who are in the community. I think, have they been set up at sufficient scale and speed? I think the answer to that would be no. But is the service probably better, faster, more efficient than elsewhere? I think the answer would be yes. So more to do, Emily, and hopefully, if you're calling as somebody with long COVID, then hopefully you can access those clinics and access the research.
Great. Professor Chris Brightling, thank you for a really interesting lecture and for delivering this year's Jacobson lecture. If we were live and in person, you'd now be listening to resounding applause. So you'll just have to imagine. But thank you very much.
Many thanks.
And thank you to you, our audience, for listening and for participating in the questions. Our next lecture is on the 18th of May, next Tuesday, and we hope some of you might be able to join us. It will be given by Iman Atta, and it's titled Islamophobia, the rise of anti-Muslim hate crime, why it is rising and what can be done. So thank you very much again, and enjoy the rest of your evening.